Thank you so much. And it was all I could do to not ask a question during that last session because I don't remember if it's Keith Stewart that said it or if I said it. I think each of us credit the other. But allo and myeloma is a choice between dying of myeloma or dying of myeloma and graft versus host disease. So, sorry, Herman. I didn't ask it, though. So I think as we begin to talk about immune therapy and myeloma, fortunately, the field is expanding well beyond simply what's available in the context of allogeneic transplantation. And I always think it's important as a first step to really look back on why I think in immune therapy and cancer in general, we've been so unsuccessful in terms of moving the field forward. And this was, I was sitting in my bathroom getting ready in the morning, and National Public Radio came on with this really earth-shattering statement from a Johns Hopkins immunologist suggesting that perhaps there were differences in the mouse immune system from human immune system. And having written many papers and many grants that were rejected by mouse immunologists because they didn't understand that humans were different than mice, I knew this 15 years ago, but apparently it's novel now. So I think this is an important lesson because we are, in fact, quite different from the mouse biology. Now, when I think about immunotherapy in the context of myeloma, I really think about it in three different categories. And I think about it in the context of passive immunity, which is typically a monoclonal antibody. And historically, we've talked about targeting the tumor, but more recently, there have been newer approaches talking about targeting the microenvironment or other cells within the microenvironment through monoclonal antibodies that may have clinical relevance. We also talk about what I call adjuvant therapy, which is an immune booster. And the analogy that I like to think about for this, having just flown through Charles de Gaulle, is you arrive and your plane that you're supposed to go someplace else is on strike. That's the akin to getting a vaccine when your immune system is not ready to receive that vaccine. The vaccine can be the best vaccine in the world, but if your immune system is not primed or prepped to do something with that adjuvant, it's really going to be relatively ineffective. And fortunately here, you're stuck in Paris, which is not so bad. But in Atlanta, if you fly Delta, it may not be quite the same thing. The third is active therapy, which is delivering live cells. And as you know, allogeneic transplant has been the main mechanism by which to do this. But we do have some CAR T-cell concepts that I think are really quite promising that I'm going to touch on, as well as other ways of giving antigen-specific T-cells now that are auto, not allo in nature, and may help us to sort of enhance immunity in any kind of a treatment setting. So when we think about myeloma therapy, I always like to say when you're applying a treatment to a given patient, what are you trying to achieve with that treatment? And in the context of immunotherapy, it probably varies. So if you take a patient who's got refractory myeloma, 5 prior lines of therapy, borderline counts, little hope for the next few months, all you're trying to do is target the tumor. That's your main goal. Eradicate the disease, get them into a partial remission or better, and hope that something else good comes along until that disease fails. But when you're in the context of relapse disease, it's a little bit different. Your goal in that situation is to really target the tumor. That's the same. That's almost always there. But you also want to allow some restoration of normal immune function so that a patient can hopefully create host anti-tumor cells that will then give you prolonged anti-tumor effect over the period without having to give sustained therapy for an indefinite period of time. When you're in the context of a newly diagnosed myeloma patient, it's obviously trying now to achieve MRD negativity and prevent clonal evolution. That is a major goal of immunotherapy in the context of newly diagnosed myeloma, and I think there are some suggestions that that certainly is possible. And now that we're beginning to treat patients in the pre-malignant state, whether it's MGUS or smoldering, I think that the goal here is really prevention through targeting the microenvironment and not allowing a patient to develop symptomatic myeloma or eradication of the clone altogether using purely immune-based mechanisms. And so these goals need to be kept in mind when you're thinking about what to do with a given patient at a given time. So I'm going to really focus a little bit on 3 different kinds of treatment approaches. And you've seen a lot of data for most of this, so I'm going to go data light and really go more theoretical in terms of immune therapy and not show you slide after slide a PFS curve with every monoclonal antibody out there, but really talk in principle about what the antibodies may be helping us to do. So as we think about targets in myeloma for exploration of monoclonal antibodies, you've really got several different classes of monoclonal antibodies that I think are there. And the ones on the right are ones that are focusing more on soluble factors, things like siltuximab, which targeting IL-6 did not get us a lot of mileage. There's now tabalumab, which was targeting BAFF, which also did not get us a lot of mileage. But there are now antibodies targeting APRIL, a way to perhaps prevent BCMA-dependent signaling in survival. These are now being tested in phase 1 studies and may actually be quite promising, as we know that BCMA is an important target for myeloma cell survival. So if you prevent something like APRIL from interacting with the BCMA receptor, you may prevent that positive signaling cascade that's important for cell survival. We know there are other ones such as CS1 and CD38 where we have a lot of data that's currently ongoing. And then, of course, things at the bottom that you can see here like PD1, CD38, and BCMA on the right. These are all fit for current studies. And in fact, CD138 was a target we were very excited about. We had an antibody-drug conjugate that actually seemed to have not a lot of activity as a single agent, but when combined with lenalidomide, seemed to overcome lenalidomide resistance. But for some reason, that company seems to have dissolved down a drain, and that drug is not moving forward at this time point. But certainly 38 is probably a more specific marker than, say, CD38 or even than SLAMS7 if you think about our current available armamentarium. Now with daratumumab, again, obviously there's the direct anti-tumor effects, but it's probably the immune effects that are more interesting and exciting. And in fact, I've been trying to talk our allotransplanters into using daratumumab in the context of preventing Treg proliferation and downregulating MDSCs as well. This to me actually does make a lot of sense, and whether it's an in vivo or an in vitro purge, I think this is really an interesting concept, because what we know is that CD38 is not just present on myeloma cells, it's present on a whole host of other immune cells. And so trying to take advantage of its immune-based effects, those on the right, are probably far more important in terms of long-term disease control than targeting just the tumor itself. And figuring out how to do that, I think, is an important goal for the next few years as we optimize the use, schedule, frequency, and partners of drugs like daratumumab. At the same time, elotuzumab also has many functions as well, and I think we're just now beginning to explore them. It can partner with other drugs as well and does have the effect of potentially activating NK cells and causing their enhanced activation and proliferation. How do you combine this with existing drugs in the current realm of antibody-based therapy, I think, is an important question, and these are things that are now beginning to be explored. I know I'm very excited to see the German data looking at ELO in combination with LEN in the maintenance setting, because that may actually be a really important place where reconstitution of normal immune function and NK cell number may actually have a bigger bang than it does in the newly diagnosed or relapse setting. And so I think those kinds of studies with intense immunologic correlates are really important in people, not in mice, in people, to really help us change how we treat patients. And then I don't think we should forget the important role of the IMiDs. And the reason I say this is that IMiDs obviously have a direct anti-tumor effect, similar to what we talked about with daratumumab. But IMiDs also have a pretty significant impact on NK cells and T cells as well. And so as we think about the efficacy of an IMiD in a patient whose myeloma is resistant to the IMiD, it may actually be working through a different mechanism. So when you target a myeloma cell with a drug like lenalidomide, pomalidomide, or thalidomide, you target cereblon that results in downregulation of Ikaros and Aiolos, which then results in downregulation of IRF4 and MYC, which then results in myeloma cell death. But at the same time, if the myeloma cell is resistant to that approach, you've got a whole nother mechanism of action at play where the same target, cereblon, is being hit by pomalidomide, lenalidomide, and thalidomide. You downregulate Ikaros and Aiolos, but you actually upregulate IL-2 and downregulate TNF, and at the same time result in T cell and NK cell activation. And this is actually really important because it means you can reuse the IMiDs as an immune adjuvant when you're giving an immune-based therapy, even if the primary disease is resistant to an IMiD. So I don't think this is a consequence of clonal tiding or clonal evolution. I think it really has to do with a very different mechanism of action for the IMiDs where it does activate immune cells. And that likely, if you have an effective T cell or NK cell, should work regardless of whether the patient is sensitive or resistant to an IMiD. And of course, this brings in the question of third and fourth generation IMiDs, which are being developed right now in phase 1 trials and may may actually have more potent immunologic effects than thalidomide, lenalidomide, or pomalidomide, as we've seen in the last decade or so. Now, as evidence of that effect of the IMiDs on NK cell function, this is a nice figure demonstrating both in healthy donors as well as in myeloma patients that NK cell T function and NK cells go up nicely in combination with lenalidomide in terms of activity and function. And this really does give rise to the efficacy of many drugs that we use in partnership with medicines like lenalidomide. But at the same time, I think this is really an important story. We've always been concerned about the impact of daratumumab on NK cell function and number. And it's clear that when you give DARA, NK cells numbers go pretty low to the basement, if not lower. And that's an on-target effect. That's not a big surprise. But when you partner an IMiD with daratumumab, you actually may see recovery of NK cells over time because of that effect the IMiD has on NK cell function. And this right here shows the NK cell numbers in a single patient who received DARA in combination with pomalidomide. And as you can see, while the NK cell number went down pretty quickly in that first cycle, by the middle of cycle 2, NK cell numbers were about 75% of where they were before. And this may be a consequence of immune recovery following treatment and clearance out of myeloma, but it likely also has to do with the effect of an IMiD on NK cell recovery. And this, I think, really speaks to the impact of IMiDs in a non-anti-myeloma way. This was a patient actually at our center who was treated on PomDex and had progression, as you can see by the M spike, but then was treated on a DARA PD-1/PD-L1, and I can't tell you the drug because it's a secret, but it was a drug that targets either PD-1 or PD-L1 in combination with DARA. The patient briefly had a response, but then had progression, and as you can see, we added back in pomalidomide, and the patient responded again. Why? Well, it's not because POM was killing myeloma. It's probably because POM was doing something in partnership with PD-1, PD-L1, as Mari V has shown in her previous studies, to reactivate the efficacy of the effector cell, making that monoclonal antibody more effective. So what about checkpoint inhibitors? I briefly touched on the idea of PD-1 and PD-L1 in myeloma. We know that there's a lot of noise around the pembrolizumab story. There will be more data that's presented at ASCO that speaks to not just what was the outcome as was released by the FDA, but what were some of the causes of morbidity and mortality, and are those in fact myeloma related, or were those somewhat unfortunate random events? I think this is an important question for us to address as the myeloma field, knowing that there are other PD-1 and PD-L1 inhibitors that are in development, and at least from what we've heard through the Wall Street Journal, and I've not seen that same negative signal with those other antibodies as we've seen with pembrolizumab. But I think the bigger question is, can we identify subsets of patients who in fact be more sensitive to targeting PD-1 or PD-L1? And should we identify patients who perhaps should not receive PD-1 or PD-L1? And I'll tell you personally, we still have a lot of interest in targeting this approach. PD-1 and PD-L1 clearly from data that was presented in phase 2 studies has activity in combination with an IMiD. But I don't know that it's ready for smoldering, and I don't know that it's ready for newly diagnosed myeloma right now. But in the relapsed refractory setting, clearly there were patients who had responses, and trying to figure out a biomarker to identify those patients, I think, is really critically important. Now, what about other targets in this space as well? Well, you saw this from Dr. Neary yesterday, a nice description of a lot of the inhibitory and activating receptors on T cells. And I can tell you we know in myeloma that perhaps things like LAG3 or TIM3 may have significant interest in activity in the context of myeloma. And in fact, LAG3, as I think Dr. Neary showed you yesterday, may be an important one independent of receiving prior DARA, but also may be important in the context of DARA exposure as well. So these are antibodies that are currently in development that we're hoping to test in the context of myeloma alone and in combination with IMiDs to try and sort of get this concept jump-started again and get some of these drugs into our patients where clearly we know T-cell function and T-cell activity is a major detriment for long-term outcomes. Now, what about other monoclonal antibodies? We know that monoclonal antibodies in general have been quite successful. We've talked about things like elotuzumab or daratumumab that are direct anti-tumor binders, work through ADCC or ADCP. Those are the figures on the right. What about conjugated monoclonal antibodies? I'm going to touch on that in a moment. There were a couple that were in early clinical trials and one that is certainly on its way to larger development. That's the GSK compound that I'm going to talk about in just a moment. But I think the idea of the bispecific T-cell engagers, particularly those with BCMA and CD3-based approaches that are in phase 1 trials, are a really interesting concept. And to me, the question, and I don't know the answer to this question, is your innate immune function going to be good enough to have T cells that are going to engage with the other side of that BiTE or bispecific antibody? Because if they're not, then you're going to engage BCMA on the tumor cell, and you're not going to have anything on the other side that's just floating open. And so I think, is T cell function really good enough to affect responses? And I've heard some anecdotes from people that suggest the answer to that is yes. That would, I think, be really exciting. And of course, in my view, if you're going to combine a bispecific or a BiTE, combining with an IMiD might be the perfect partner to really activate NKs and T cells to let them be even more effective bispecific or BiTE-based anti-tumor effects as well. So this, I think, is an early story, but I suspect in 2 years we will be on the road to having something approved in this region, and hopefully it'll be even better or faster than that. What about the antibody-drug conjugate? This is data on the GSK antibody-drug conjugate. I'm not going to refer to it by the number of 2857916, except that one time. I'm just going to call it the ADC, because right now it's the only one that's really moving along in the context of myeloma. This is a BCMA-directed antibody-drug conjugate, but it does still retain the ability to fix complement or to engage in ADCC. So it does deliver a drug directly to the myeloma cell, but it also does bring in immune function as well. And this was the response in part 2 of that trial. Again, you can see a significant response rate for a number of patients in this. And in fact, if you look one step further, this is the depth of response. A large number of patients achieved CRs, VGPRs, stringent CRs, and PRs. And if you begin to look at the numbers in aggregate, it was about 60% of patients that had a response. Now, this is a very small number of patients, but if this holds up in a larger phase 2 study that's planned at this time point, it would be the single most active drug in myeloma at this time point. Remember, all the other drugs we use are roughly 30% single agent activity. So this would certainly be a huge step forward and really validates the concept of BCMA as an important target in the context of myeloma. Now, what about vaccines? I've got a vaccine to talk a little bit about. This is PVX-410. This is an antibody that Nikhil Munshi and Ken Anderson worked very closely on to do some early development work. This is a peptide antibody that really targets XBP1, CD138, and CS1. And there was a trial looking at this as a single agent in the context of smoldering myeloma. It was then moved on to add in lenalidomide and is now looking at lenalidomide plus this vaccine in different myeloma settings pre and post-transplant. This is data on that PVX vaccine in terms of responses that you can see. And again, what I think you notice is predominantly stable disease when the vaccine was given alone. But when you bring that plane into the airport so that the vaccine can do something, you do actually see better responses here on the right when it was combined with lenalidomide. Again, this is actually some of the flow plots on some of those patients demonstrating pretty significant increase in antigen-specific T cells that are being primed with XBP1, CD138, or CS1. Again, this is a really interesting concept, and we're now waiting on a larger phase 2 study to look at a number of different populations for this vaccine as well. Just to move on, taking vaccines to the third level, which is obviously a phase 3 trial, this is David Avigan's slide where he's looking at the BMT-CTN, where he's actually going to do a dendritic cell myeloma cell fusion vaccine in a randomized fashion where patients either get lenalidomide alone, lenalidomide with GM-CSF, or lenalidomide in combination with the vaccine and GM-CSF. His early phase 1, phase 2 study demonstrated significant anti-tumor effects, and really to validate this patient-specific vaccine requires a large randomized phase 3. We've put a number of patients on this. I think it's about 25 to 30% the way enrolled so far. This, I think, does represent a nice phase 3 approach at vaccine-based treatments. And finally, I'll wrap up a little bit with CAR T cells. This was the data presented by Jesus Berdeja at ASH this year, so I'll go through this relatively quickly. Again, a standard phase 1 dose escalation study. The overall number of patients treated in this trial were relatively small, 21 patients as of October of 17, heavily pretreated. Timing of getting a patient onto a CAR T cell protocol has to be just right. They have to be progressing at the right rate at the time time the slot opens up, but certainly it's a very encouraging concept. If you look at treatment-emergent adverse events, cytokine release was present in about 70%, but only 2 patients had grade 3 or higher CRS. Neurotoxicity in general was there. There was 1 patient who had pretty significant neurotoxicity, and then the others are pretty relative. Now, what I think is important, because I think Dr. Einslow really nicely pointed out some of the data with ALL and with diffuse large B-cell lymphoma, and I'll tell you, if all we got out of a CAR T-cell in myeloma was what they got out of it in ALL and diffuse large B-cell lymphoma, I wouldn't be that excited about it, because that to me is a little underwhelming. It's only about 30% 2-year or 1-year PFS, and that to me is not worth the $500,000 cost of a CAR T-cell, particularly in a disease where we have as many patients as we do in myeloma that could potentially be eligible for it. What really struck me was the overall response rate in the myeloma trial was probably higher than we saw in diffuse large B-cell lymphoma and in ALL, and at least with short follow-up, 9 months was the median follow-up so far, the duration of remission seems to be longer as well. Now, this is a very small series of patients. I'm not going to tell you this is the answer, but at 9 months, certainly the PFS looks pretty good. The responses are relatively quick, and the overall response rate, again, early on was 100%, dropped to about 94% with a little bit longer follow-up, and this is now being tested in a phase 2 study around the world where we're enrolling lots of patients. I think target is 80 patients in total, and hope to have data within a year. Now, there were patients that did progress, as you can see here. There were patients with low and high tumor burden, patients that did have a response and lost it, patients who never had a response, and the cell dose was pretty reasonable for most of these patients. So we don't quite know who is going to have that sustainable long-term remission versus who isn't, but at least for now, it looks like the fraction of patients that have at least a 9-month response, durable response, is higher in myeloma than it is with CD19 targeted approaches in the context of large cell or B-cell ALL. So again, the summary is this looks very exciting, and hopefully within the next year we'll have additional data. There are, of course, other CAR T-cells that are in development. The NCI had one that is currently part of the Bluebird program. There's the Nanjing CAR T-cell. There's the Novartis CAR T-cell. Kite also has a CAR T-cell. Juno also has a CAR T-cell. So there are lots of different companies that are stepping their foot into this water, and hopefully with each subsequent generation we'll get better and more effective in terms of sustainability of that CAR T-cell, because that often is the predictor of long-term remission, how long you can keep these cells around, with or without all the side effects that come along with that. So in summary, again, I think immune therapy of the future will be monoclonal antibody, cellular, and vaccine-based approaches, and you'll hear more on this tomorrow from Dr. Anderson and his amalgamation of how we're going to put it all together. I think combined plasma cell-based approaches, IMiDs and PIs, with immune-based therapies gives us an opportunity to increase the cure fraction of patients. I actually, in agreement with Bart, will think that there's about 15 to 20% of patients right now that we are in fact curing. Maybe I'm living in a dream, like our previous speaker suggested, but I think that exists with our currently available agents, and I think our role with these new drugs is to try and increase that to 50, 60, or even higher percent, and I think we can do that. And if we increase the cure fraction of patients, all of this discussion about the cost of our treatments will start to drift away, I think, because then we'll have rational data that suggests a fixed duration of treatment can result in 60% of patients being treatment-free and ultimately cured of their disease. That's a very different discussion than, well, I'm going to get you to a CR, but you have to be on maintenance therapy for 10 years. That's a different cost discussion than I think where we are right now, and hopefully we can get there in the near future. Thank you.